Hi, welcome to Integrated Health Services video introduction of our Management Services Agreement Ancillary Services Program. Integrated Health Services is a conglomerate of corporations that serve the healthcare industry. We license and we contract with laboratories, specialty laboratories, hospitals, surgical centers, pharmacies, compound pharmacies, and other entities to provide services to our clients. Integrated Health Services was established in 2008, and we are currently in approximately 10 states and growing. The purpose for this introduction is to give you more of an understanding of who we are and what it is that we do, so you can make an educated decision as to if we're right for you. With our management services agreement model, we have a few goals. One is for us to provide and to build an infrastructure to provide all services in-house. Traditionally, our providers will refer out laboratory, pharmacy, MRI, and other services. And in doing so, not only do you lose a certain amount of control, but you also are not able to share in the profitability of those services. We also create professional partnerships with like-minded organizations. So we're able to use our numbers to contract with different critical care hospitals, out-of-network and in-network hospitals, ambulatory surgical centers, and other entities that are very amenable to the method in which we do business. We're also able to position ourselves to ensure compliance and protection of everybody involved in our healthcare model. We say that our middle name is compliance, and in everything we do, we run things through our attorneys first, both state and federal attorneys, to ensure compliance and safety. The way that our MSO models are set up is that we have management services agreement with various entities. Now, under the OIG, you want to exclude any clinical services and any marketing services. You always want to be compliant, so we do management services agreement in which these entities offload some of their administrative services to Integrated Health Services, and we're paid fee for service within fair market. We are then able to subcontract some of these services to other corporations, and we have to pay those corporations fee for service within fair market for those things that they do. It is compliant under the law for physicians or chiropractors or even non-healthcare practitioners to have ownership in those subcontracted entities. The way that they are then paid is through distribution as owners. These entities bill under their own contracts. So it never matters if you're in network or out of network, or if you're an MD, a DC, or a DO, or even a DDS. So we do deal with some DDSs. They bill under their contracts that are already established before we ever sign with them. This is how we leverage. When we sign with a critical care hospital or an urgent care hospital, or even a freestanding autonomous lab, if they were able to secure good contracts, then we know exactly what the reimbursement is going to be. In our model, we do not do the standard MDDC practice. In certain states, such as Texas, MDDC practices are illegal. A medical practice has to be 100% owned by a medical doctor. A chiropractic practice has to be owned 100% by a chiropractor. So in our model, we integrate the different functioning while each practice maintains its autonomy. Some things to be considerate of when you're doing management services agreements or looking at revenue sharing in any manner are the federal and the state laws. Now, even though we do not do federal reimbursement, or we do not accept federal patients, we still aspire to be compliant at the federal level. That way we're good in every state, and there's a lot of gray area or a lot of room for error in case a mistake does happen. The first is going to be the anti-kickback statute, which of course is a federal statute, and it precludes anybody who refers from being paid for those referrals. So what our attorneys have put together is an arm's distance relationship in which we exclude any clinical services and any marketing services, and every dime that moves is according to a federally compliant contract, and it is always fee for service and always within fair market value. The contracts have to be a 1-year minimum contract. That means if we put together a management services organization and you have 20 practitioners, if some of them aren't contributing, you cannot reduce the shares, you cannot change the nature of the contract within 12 months. We try to keep the group small because they're more controllable in that way. Distributions are not value or volume based. They're based on your percentage of the MSO. They're based solely on investment and never on your own productivity. We offer pain management and manipulation under anesthesia. In our pain management program, we have interventional pain managers who perform epidural steroid injections, facet blocks, microdiscectomy, and anything else under the umbrella of pain management. We also do manipulation under anesthesia. We combine the two programs, and when the referring office desires, we often do those two together. We contract with surgical centers, both out-of-network and in-network surgical centers under management services agreement. So what happens is you're also able to share in that part of our revenue model. We do electrodiagnostic testing. This is very important. For instance, if a patient is going to receive an epidural steroid injection, that Medicare standard says that they should have an NCV. Why? Because if somebody has a nerve root compression with radicular pain, it should show on the NCV. So they tend to go hand in hand, and with our carotid ultrasound and our musculoskeletal ultrasound, it creates a complete insight into what's happening with the patient at that level. These are some of the states that we were in. This needs to be updated, where we're just going into New Jersey and a few other states. What is neurodiagnostic testing? It's when you measure the amplitude and the velocity of nerve impulses through the peripheral nervous system. It's a way to quantify the function of a nerve. Now, in order to do these properly, they should be done with EMGs. EMGs are actually looking at the muscles themselves, and it's one way to distinguish between a neurogenic problem and a problem that's actually, you should say, myogenic, that's coming from the muscles. In order to qualify for an NCV, an EMG, the patient, part of the differential diagnosis should be rotator cuff syndrome, adhesive capsulitis, or segmental dysfunction of the SI joint. You can also do post-surgical knees or any type of ligamentous problem for the knees. Some of the indications, of course, anytime you have nerve root compression, you tend to have numbness, tingling, or weakness. You can do upper and lowers, You can do them separately, and we usually don't do uppers and lowers the same day. Pharmacy. We do a lot of compound pharmacy. So very often patients either aren't tolerant of oral drugs, or don't like to be drowsy, or just preferentially don't want that in their system. Also, depending on the mechanism of the pain, very often by using a lidocaine patch or another patch, pain patch, or using a compound, you're using a totally different mechanism that can often be effective when the oral medications aren't. So we do a few things. If the patient's going in to have any type of surgery, even injections, we have 4% chlorhexidine wash, which reduces staph infections by 65%, MRSA infections by 65%. They've been FDA approved for about a year now. We also do pain compounds, SCAR, for any patient who's had surgery, patches, and any of the other common pharmaceutical needs that you would have. On the laboratory side, we do general wellness panels. Every patient can have a wellness panel once a year. We also do Boston Heart panels, Cleveland Heart panels. We do urinary drug screenings for toxicology. Now, if a patient is currently on medications, they can do this. If you're going to put a patient on medication, they can do this. If a patient is going to be put under anesthesia, you can do a urinary drug screening. You would not refer a UDS or tox for somebody who is not on meds and who you're not going to put on meds. And generally, you're going to do this hand in hand with the pharmacogenetics, which is DNA, which is going to tell us what drugs work best in the system, which ones are going to be effective, which ones are contraindicated. We do cancer screening, and the patient doesn't have to personally have had cancer, but if the patient has, on some types of screening, even a third-degree relative, great grandfather, a third-degree cousin that has had cancer, or indications, or positive, what we call BRCA1 or BRCA2 findings, then the patient can get one. We also do cystic fibrosis, particularly anybody who's pregnant or who intends to be pregnant, who's trying to get pregnant, qualifies for a cystic fibrosis. Also, anybody of Ashkenazi Jewish heritage, since you find it high incident rates in that population, can have a cystic fibrosis test. As we looked at different lab offerings, we've been through quite a few labs, and we have very good labs right now that are very transparent in what they're doing, will give you the results. Any patients that have positive cancer screening, doesn't mean they have cancer, but if they're at high risk, then actually somebody will call them directly, a counselor, and will explain exactly what that means to them. These are the basics of what we offer. In our program, to get to this point, you've already signed a non-disclosure agreement. The next phase would be for you to show positive interest, and then we would put you, unless you have your own MSO, we would put you into an MSO with other individuals. If you have a group that you want to be put into an MSO, we can put you into an MSO. If you already have one formed, we'll just contract with your MSO. So what happens is we have the master contract as Integrated Health Services. We would then do a subcontract for management services that would contract your LLC to do certain administrative functions. You can either hire people in-house to do this, or we can coordinate independent contractors that will do these duties for you. The MSO will pay them, making their work product your work product, right? Has to be fee for service. The services have to be able to be documented, and it has to be within fair market. If you have any more questions, your contact with IHS will follow up with you after this. Thank you for joining us. Have a great day.